Welcome to the Mom Submit YouTube channel. In this video, we're going to be breaking down how to create space in the bottom of the pelvis to help support pushing preparation, to help support your baby vacating the premise. And so we're going to be talking about the physical mechanics of creating space in the pelvic outlet, why that is not enough to be thinking about for the pelvic outlet. We're going to talk about the soft tissues and how to help them yield, because if you didn't know, your pelvic outlet is mostly soft tissue, and so we want to learn how to relax those tissues more so than how much we can torque our hips into different positions. And then we're going to talk about pressure mechanics. So how does your rib cage position impact how well that you can push? Because you might think just knees and ankles out, I create space like that, but we also need to be thinking about our rib cage positions, because that's going to influence how strong our pushes can be. Hey, my name is Gina. I'm a perinatal fitness trainer and birth doula.
And I'm Roxanne, my certified nurse midwife.
And we're going to be talking about how do we create more space in the bottom of the pelvis to help support pushing. So when it comes to pushing and preparing for pushing, typically what we see on social media is knees in, ankles out. And that's going to create that internal hip rotation or internal pelvic rotation to spread the ischial tuberosity, so those are your two sits bones on the bottom of your pelvis, laterally. So it's going to create more space side to side. And that is helpful. It is helpful to physically create more space in the bottom of the pelvis with that internal rotation. However, there's a lot more that we need to be thinking about. The pelvic outlet is mostly soft tissue, and there's a lot of hormones during pregnancy that impact the laxity and the flexibility and the softness of the tissues, and those increase during labor as well. There are a number of hormones that impact the laxity and the softness of the tissues throughout the body, but especially with the pelvic outlet. So the pelvic inlet has a lot of bony architecture that it's really important that we're creating a lot of space physically with the bones. The mid-pelvis is the narrowest space because of the bony structure. Again, really important that we can create a lot of space and have good pelvic mobility. But when it comes to the pelvic outlet, because there's so much soft tissue, learning how to yield those tissues can be incredibly important. And so we have a number of hormones that impact this laxity and softness of those tissues. We have estrogen, which is going to increase blood flow to the tissues, which can help them be more flexible. We have relaxin, which is going to spike during the first trimester and be fairly elevated throughout pregnancy into the postpartum timeframe. That helps to increase joint laxity. So it's going to help to kind of stretch and move that stuff a little bit more. Before labor begins, we have progesterone, which is helping with smooth muscle relaxation, but that does decrease before labor begins. And then during labor, we have prostaglandins, which is also helping to kind of soften all of these tissues. And so when it comes to preparing for pushing and creating space in the pelvic outlet, we do need to take in consideration that there is just less bony architecture in the pelvic outlet. And so learning how to relax these tissues, to relax the pelvic floor is incredibly important, and maybe even more so than how much can you torque the hips into internal rotation. Another thing to take in consideration when it comes to opening the pelvic outlet is the rib cage position. And we actually had, I think it was a doula comment on one of our Instagram posts where we were talking about rib cage positioning for pushing, saying that she has never heard of the rib cage being important at all for the pelvis. And so it's important to note that your pelvis attaches to a spine that then also attaches to that rib cage. And so when Roxanne finds more of an arch in her back, so she finds more of an anterior tilt, a little bit more spinal extension, her pelvis is also going to tilt more forward. So we're going to have more of an anterior tilt with her pelvis. If she found a more rounded position where she rounded in her back, she's going to find more of a posterior pelvic position. So that pelvis is going to tuck underneath. And so her rib cage position very rarely is going to move independently of the pelvis. And so if Roxanne tried to keep her pelvis tucked and arched her back, she would probably have a really hard time doing that. Her pelvis is intuitively just going to shift because rib cage position impacts pelvic position. To start with rib cage position impacting pelvic position, if we have a more rounded position, this is going to make that internal rotation easier to achieve. So it's going to feel more intuitive and comfortable because the way that the femur is positioned into the pelvis in this tucked position, which we're gonna find with more of a rounded back position, that femur head is gonna more easily be able to rotate internally because there's gonna be space allowing for it. If Roxanne found a more arched position, so she found more of that extended position, that anterior pelvic tilt, arch in her back, which again, she could really not do this independently of each other, and then found more of that internal rotation, so knees and ankles out, she's probably gonna feel a lot of strain in the lower back, a lot of discomfort within the hip, because the femur position changes in that hip socket and it's gonna be much harder to find internal rotation. So this position is probably not super comfortable for her. So rib cage position does impact the ability to open the pelvic outlet because we have this connected chain here. So however her rib cage's position is gonna impact how her pelvis can position, and the pelvic position impacts how the femurs can move within the socket. So we cannot think about pelvic outlet as only the pelvis. We also need to take into consideration the rib cage positioning. The second part of that is the rib cage is where the diaphragm is, and the diaphragm is the main mover for pressure mechanics. And so this is how we are going to increase pressure within the abdominal cavity to help increase the strength of our pushes. If we are in a more arched position, the diaphragmatic angle is going to be towards the belly and towards the front. And so if Roxanne took a really big inhale, she's going to feel more pressure into the front side of her body. In addition, she's going to have a hard time finding internal rotation in this arched position. So in general, a more arched position is not going to be optimal for pushing mechanics. Now, if she found a slightly more rounded position or even just a neutral spine position, maybe just like a slight tuck underneath, this is going to help to align her diaphragm more towards the pelvic outlet. So this is going to be a more direct line of push for her. So when she inhales, that diaphragm is going to move straight down. And so that direction of effort is stacked on top of that fundus, so the top of the uterus. And we're just going to have this direct line downward into the pelvic outlet. And so that increase in pressure is going to help to increase the strength of the pushes, because pushing is a pressure management activity. So we increase pressure in the abdominal cavity to help push baby out of the bottom of the pelvis. And so rib cage positioning does in fact impact the ability to push well and to create space in the bottom of the pelvis. So understanding pelvic mechanics is really helpful to physically creating more space in the bottom of the pelvis so we can find that internal rotation, to create that side-to-side opening in the bottom of the pelvis. But we also need to keep in mind that we have a lot of that soft tissue that we need to learn how to yield, in addition to understanding the rib cage positioning and its impact on the pelvis and how well that can impact the femur movement. So how well can we create that internal rotation within the pelvis? And so Roxanne, when it comes to pelvic mechanics, I think it's really amazing that there are more providers and more nurses that are aware of, okay, when somebody's pushing, we don't want them to find knees super wide to create space for the baby, because we could actually be decreasing physical space for baby. But it's not just knees and ankles out. So how has that kind of elevation helped you as a midwife?
I think it's important to know, like, when someone's pushing, a lot of the time, while we want to wait until baby is +2 station and in the outlet to push, most people start to push while their baby is still in the mid pelvis. For most babies, when we start pushing, they're not at +2 station yet. They're usually still in the mid pelvis. They're not really +2 station until they're low enough in the pelvis that we can kind of see the head without having to like put our fingers in there or anything. They're just at the introitus or the opening of the vagina. And that usually means like they're pretty far down in the pelvis already at that point, but they're still rotating through until they get underneath that pubic bone. So while they're rotating, they still need that space within the pelvis kind of asymmetrically in order to finish that rotation, even at +2 station for some babies. So by creating just the knees in, ankles out, yes, that is creating some space a little bit, but we also need space posteriorly too for the head to get underneath the pubic bone. And sometimes knees in, ankles out could decrease the ability of the baby's head to rotate just in general. So doing asymmetrical pushing positions usually I find are a little bit more helpful to get baby underneath the pubic bone and then be able to extend their head out versus doing knees in, ankles out, outlet movers while the baby is still trying to rotate through and get underneath that pubic bone while they're not hurting anything, but they're maybe not the number one best position. So there's so many different types of asymmetrical positions that we can use. Still thinking about internal rotation, but maybe internal rotation on only one side and then external rotation on the other side. I've been seeing to be more helpful with pushing to get that baby fully underneath the pubic bone versus just thinking about knees in, ankles out.
So some of the asymmetrical movements that we can do, so it's not just knees in, ankles out, we have that internal rotation, which yes, moves those ischial tuberosities laterally, but remembering, like Roxanne was saying, that most babies are not in the pelvic outlet when we are pushing. They're still mid-pelvis, and so asymmetry can still be really helpful when pushing. And so instead of thinking just bilateral internal external rotation, we can add in some asymmetry by either just shifting the weight towards one side, typically the left, because most babies are rotating on the left side. With the right leg, we can actually find a little bit more external rotation, so feet come together. So that right leg is more externally rotated, this left hip is more internally rotated. And some people will intuitively do this when they are pushing in hands and knees. They're just gonna shift a little bit to the left side. They might find a little bit more external rotation on the right side. If we want to enhance this in some different ways, you can either get like a rolled up blanket, if that's all you have, or sheet, place it underneath the left knee. You can get like a pillow and fold it in half, because usually the hospital pillows are pretty flimsy, and put that underneath the knee. If you happen to have a yoga block, you can also put that underneath the left knee. But again, we're shifting the weight over to the left side. So this left lower mid pelvis is lifting up, which is going to help baby to rotate underneath that pubic bone. Because again, most babies are still mid pelvis when we are pushing. We can also do this in a more supine or side lying position, where instead of grabbing both legs to pull back and finding tons of internal rotation, they can just grab their left leg and pull towards themselves. And this asymmetry can help to create that space in the lower mid pelvis as well on that left side to help baby get underneath that pubic bone. So right leg could be a little bit more external rotated. It can just be straight, so they can just fully extend that leg. If we need some support, we can use pillows. So what is happening here is when she comes into this position, that left pubic half is lifting up, and that's going to lift up that space to help baby finish rotating. So that left half lifts up, and then there's more space for baby to rotate to get underneath that pubic bone. And so I personally have had a lot of success as a doula, where if that baby is just kind of like rocking and rocking underneath that pubic bone, we find some sort of asymmetrical position, and then this helps that baby get underneath the pubic bone. In addition, if we can bring that right leg more externally rotated, it's going to help to torque the pelvis. So this right posterior pocket is contracting essentially to really allow that left pubic bone half to lift upwards. And so if we find that asymmetry with left leg a little bit more internally rotated, closed, right leg more externally rotated, more open, this is going to help to kind of open up that pelvis diagonally to help baby finish rotating underneath the pubic bone while pushing. So in addition to physically creating more space with different pushing positions, we also need to learn how to yield to soften the tissues, because the outlet is mostly soft tissue as well. So it's mostly the pelvic floor. We have connective tissues, ligaments, the perineum. So there's not as much bony architecture impacting the opening of the pelvic outlet. And for a lot of folks, we have normal asymmetry within the pelvic floor. And so if you work where you do internal work at all, you might notice that the right side of the pelvic floor, or the right side of kind of that pelvic wall area, feels really dense or really tight and overactive or very thick, while maybe the posterior portions feel a little bit thicker. But usually it's this right anterior, kind of front right anterior pelvic wall area feels very thick. And if that right anterior portion cannot let go, it's not going to allow that right posterior portion to tighten, which is going to help to lift the opposing left anterior portion. And so we need that asymmetrical opening. But if this side of the pelvic floor is super tight, so that right anterior portion is really tight, it's going to keep that pelvic posterior portion really open and not allow the baby to get underneath that pubic bone.
So when I'm doing an internal exam, if someone is like having some trouble pushing, like baby's not coming down, or pushing for a prolonged period of time, internal exams can be really helpful for us to kind of figure out what's going on. And a lot of the time, this right front portion, it feels like a brick wall. It just doesn't move. And then if you went to the other side, you would feel it like move and like melt away like butter. Whereas this side sometimes just does not melt away very easily. And what that is doing is what Gina is saying with the bones and the pelvis, but it's also like this brick wall is preventing the baby. It's like hitting this muscle when it's rotating as well. So like moving this muscle not only allows the pelvis to open, but also allows there to be space for the baby to move their head, which, as we know, the outlet is a large majority soft tissue. So soft tissue can get in the way of the baby, not just the pelvis. We have to think about both things. So if someone is having trouble pushing and I notice that right anterior pelvic floor is tighter, or it just feels like this is just not moving or releasing, I will always ask for consent to be like, hey, this is what I'm feeling. Do you mind if I put a little bit of pressure against that muscle to see if I can feel it release? And sometimes just a little bit of gentle pressure, it's nothing crazy, just allows that muscle to like gives it like this physical feedback to be like, okay, I can release, I'm supported, and you'll feel it just give way. Sometimes it's too tight and nothing like that is helping. So this is where we can find positions to help that right anterior pelvic floor. So doing like external rotation movements on that right side usually helps them be able to release this, because it puts more focus on the glutes and less on the inner thigh with regards to strengthening and holding tension. And I've had a lot of success in previous births of releasing this muscle. This allows baby to have the space to be able to come down, and like there is so much movement in the baby's head once that is gone.
So you can think about internal releases, like Roxanne was saying, to help kind of do a trigger point release on that muscle, in addition to different pushing positions that emphasize more external rotation on the right side. So they're gonna feel more of like a groin, like inner thigh type stretch on the right side, and that's helping to kind of relax or to offload that right anterior pelvic floor. But most importantly, we don't need to wait until birth to figure out how to release and offload these tissues. Because again, most of the pelvic outlet is soft tissue. And so there's a lot that we can do prenatally to help prep. And now, if you're a birth professional, you may or may not have opportunities to work with patients throughout their pregnancy. If you are somebody that is pregnant, know that there's a lot that we can do to make this easier when labor does come. And we have a free birth prep circuit that you can join. We'll link it down below where you can grab it. If you're a professional and you want to dive so much deeper with this with us, you can check out our new pelvic mechanics course, where we break down the inlet, the mid-pelvis, the pelvic outlet in a depth that you probably have not seen before. Because if you didn't know, your inlet has two portions to it. It has an anterior and a posterior portion, and they open in different ways. The mid-pelvis has an upper and lower mid-pelvis, and those open in different ways. And for the pelvic outlet, hopefully from this, you have realized there's a lot more to it than just internal rotation, find knees and ankles out, because we need to think about pelvic mechanics in more depth if we are the birth professional. And so if you want to check out our free birth prep circuit, or you want to check out our pelvic mechanics course, we've linked everything down below. And if you want to check out any of our online courses, so we have prenatal fitness courses. If you're pregnant and you're wanting more support to prepare for this, check out our online prenatal fitness programs. If you're a professional, check out our pelvic mechanics course, and you can use code YouTube10 to get 10% off any of our online offerings.